Hi everyone, I welcome you all to the Medicoz Community YouTube platform. I'm Dr. Chris and I'm your Anesthesia faculty. I hope I'm audible to everyone. Please do let me know in our chat box. You can just give me a thumbs up and we can proceed. Alright, so before we proceed ahead, please allow me a few moments to introduce you to Medicoz Community. So it's an online e-learning platform which is specially designed for students who are aspiring to give the 2024 National Exit Test. Now this platform has many resources, like we will be conducting live interactive sessions with all our expert tutors which will help you in understanding the subject better, and you can get your concepts cleared out as well. Plus, we have designed a wide range of question banks and test series. And we are also doing a early bird offer for registrations. Please do visit the website www.medicozcommunity.com, where 3,000 applicants will be able to avail various offers across all the different plans that we've developed for you. So I hope you take the opportunity and register yourself. Alright, so today we will be doing 25 most important clinical based anesthesia questions for 2023 NEET PG exam. Out of which questions 1 to 13 I will be discussing with you today, and please do not forget to join us back on 23rd February at 8:45 p.m. to do the rest of the questions, question number 14 to 25. Alright, so let's begin ahead with our questions. So you can take down your pens, papers and do take notes of whatever you feel will be helpful for you for your exams. So in the chat box, do let me know if you have any queries, if you need me to repeat any concepts, and do keep sending your answers. So this will make an interesting interactive session. Alright, so let's dive in. So coming to our first question, a 40-year-old male patient has been rescued from a house fire. He is hemodynamically stable but has cherry red appearance of the skin and is suspected to have carbon monoxide poisoning. Which is the best device to detect carboxyhemoglobin? And your options are co-oximeter, option B is pulse oximeter, option C is capnography, and option D is fuel cell. So let's look at the key points. The patient has a cherry red appearance and they have said it's carbon monoxide poisoning. Now which would be the best device to calculate or to detect this carboxyhemoglobin? I hope you are sending me in the answers and I can have a look at that as well. Alright, so coming to our answer, the most correct answer here would be your option A, which is your co-oximeter. Now co-oximeter was first developed by the company called Massimo, and it came up with 8 different wavelengths to detect different hemoglobins. So what it does is it projects 3 wavelengths that cross through your bloodstream and it is absorbed on the other side, and whatever hemoglobin that would be present would come up on the machine. If you look at the different graphs here, you will see the different wavelengths. It can be used for even for normal oxyhemoglobin, then methemoglobinemia, sulfhemoglobinemia, carboxyhemoglobin and so on. So the best option here to answer would be co-oximeter. Your option B, which is a pulse oximeter, it only has 2 wavelengths. That is for your normal oxy and deoxyhemoglobin, and these fall under the red and infrared wavelengths. Then option C, capnography. Again, this is only used to measure carbon dioxide in the expired air. And fuel cell, which is just an oxygen analyzer placed on the anesthesia machine, that helps you to detect the fractional inspired oxygen that is going on to the patient. So you're making sure that with the fuel cell, you're delivering adequate oxygen to the patient and no hypoxia mixtures are being delivered. So I hope this cleared your doubts about the co-oximeter. Alright, let's move on to our next question. question 2, which is, what is the confirmatory sign of correct placement of endotracheal tubes? And your option A is pulse oximeter, option B, auscultation of chest and epigastrium, option C is capnography trace, and then option D is your arterial blood gas. Again, the key word here is confirmatory sign for correct placement of endotracheal tube. Please keep sending me the answers as well. So let's look at the correct option, and that would be your capnography trace. Now, as we saw in the earlier slides, capnography trace is used to detect your expired carbon dioxide levels. And mainly here what is important is you need to see 4 or more square waved sustained patterns. That all these 4 squares, as you see in the graph here, should be of equal size and morphology, and that would confirm your endotracheal placement. You will also see some trace in your esophageal intubation. However, that wouldn't have any proper morphology to it. It would just be like a haphazard wave which would then disappear. Why this happens is because of swallowed air in your abdomen. Then option A, which is a pulse oximeter, it will only tell you about oxygen saturation in the arterial blood. So even if the tube is in the wrong place at the beginning, what would happen is there will be some lag in giving you a response of hypoxia. So this is not a very good measurement. Auscultation, earlier it was the most important method before the dawn of your capnography. So you actually auscultate into upper lobes, both your bilateral lower lobes and your epigastrium. But the problem here is it's very subjective, as in with person to person, what they can listen to on the chest will differ. Plus, if the patient is a bit obese or has any lung parenchymal disease, then this would also not give you a proper diagnosis. Then option D, your arterial blood gas, that is also mainly for your partial pressure of oxygen and carbon dioxide that is present in the arterial blood, and therefore not a very good option. So the best answer here is capnography, which is also considered gold standard in confirming your endotracheal tube position. All right. So related to this question, we can have a look at different capnography waveforms. All right. So if you look at your first waveform, this is your normal trace. The normal end tidal CO2 or ET CO2 as it is known as is between 35 to 45 millimeters of mercury. So first, when you look at the waveform, look at the numbers on your y-axis. If the top portion of your waveform is between 30 to 40, that means this is of a normal configuration. If you look at the second waveform, you can only see 2 large squares and the height is quite high, as in it's almost reaching 50 to 60. So this is indicative of hypoventilation. When you are hypoventilating, carbon dioxide is getting accumulated in the body and the number shown on the screen is quite high. Then your third waveform, here you can see 4 small square wave patterns, and this top portion trace is below 30. So here the patient is hyperventilating, and that is why it is the patient is washing out the carbon dioxide from the body. That is why the number is below 30 millimeters of mercury. Then let's have a look at this one. You have one square wave and then the trace just disappears. So this is probably indicative of apnea. Here either the ventilator has gotten disconnected or the patient has stopped breathing. So after one proper trace, that means that your tube is in the right position. It's just that there is no airflow occurring in the lungs. Then look at this one. You can see like a sharp upslope to the plateau part of your waveform. This is also called as shark fin pattern. So in shark fin pattern, what happens is, if there is any upper airway obstruction like asthma, COPD or even bronchospasm, so this will give you like a sharp slope, very much indicative of bronchospasm. And coming to our last trace, here there is no proper morphology, it's just like waves and then it disappears. So as we saw in the earlier screen, this is esophageal intubation. That is, it's just because of the air which is dissolved, sort of not dissolved, absorbed or that you have swallowed in the abdomen, that would just come out, the carbon dioxide from there. So these graphs can also be asked. There's one more graph that I would want to add to this is your curare notch. Curare, you know, curarization is your muscle relaxants. So if you see like a notch at the top portion, like there's a flat line, a notch followed by a flat line, this is indicative that the patient is coming off the muscle paralysis, or the patient has started breathing after the muscle paralysis effect is being worn off. So that another trace would be like a curare notch. Alright. I hope now the traces of your CO2 waveforms are a bit more better understood by you. Alright. So we'll move on to our third question. A 2-year-old boy is undergoing ENT surgery. Which of the following anesthetic agent cannot be used for the induction of anesthesia? The option A is sevoflurane, option B is nitrous oxide, option C is halothane, and option D is desflurane. Let's look at the question again. It's a 2-year-old boy, so pediatric patient, undergoing ENT surgery, and which anesthetic agent you cannot use this for induction. Induction as in the start of anesthesia, where you're just putting your patient off to sleep. Alright. So what do you think would be the right answer here? You can go ahead and send me some options. Alright. So here the correct option would be desflurane. Let's look at the options one by one. So option A, sevoflurane. It is the preferred agent for pediatric inhalational induction. As you know, pediatric patients won't let you even take an IV cannula. So first you need to hold some inhalational gas over them, put them off to sleep or just sedate them a little bit, and then go ahead with your cannulation. So this technique is called gas induction, and for this sevoflurane is the most preferred agent. That also holds true for adult patients because it's a very sweet smelling gas. It is non-irritant for the airway, and overall the incidence of cardiac instability or arrhythmias is quite low with sevoflurane. So this is in fact the preferred agent. Nitrous oxide. So nitrous oxide is used as Entonox, which is 50% oxygen, 50% nitrous oxide mixture, and it's most commonly used in labor analgesia. Because it can, it's used in labor analgesia, tried and tested, and it can be used for induction as it reduces the dose of your other anesthetic agents that you need. And this effect is your second gas effect. Also, there's another effect called as concentration effect. Which it means is when you use nitrous oxide, the other gases that you use along with it, you can use it in less quantity. So in fact, you can use it with your sevo for induction. Then halothane. Halothane used to be a very favorite anesthetic for the earlier anesthetists, again before the dawn of your newer agents like sevoflurane, isoflurane. So halothane is also a very pleasant sweet smelling gas and has been very well tolerated by pediatric patients. However, we do not use it much these days because there has been a risk of hepatitis in the past on repeated exposure to halothane. So although it is not used nowadays, but you still can use it theoretically for induction. Desflurane. It is the newest inhalation agent which was introduced. So the importance of desflurane is that it has a very fast onset, fast offset, as in it goes in very quickly and induces anesthesia in a patient, and you can wear it off also as quick enough. But it's a very pungent gas, and it is so pungent that it can actually trigger laryngospasm. So it is absolutely not preferred for induction, be it for pediatrics or adult patients. You can use it for maintenance, but not for induction or the start of your anesthetic. I hope this solves queries with your inhalational agents. Okay. Now moving on to our next question. So you are called to the labor ward to assist the anesthetic registrar to prepare epidural infusion. Now, which of the following drug combinations are preferred? Here your option A is bupivacaine and fentanyl. Then you got bupivacaine and neostigmine, bupivacaine and epinephrine, and bupivacaine and ketamine. So let's carefully look at the question again. You are called to the labor ward to assist. So it's a normal delivery that the patient is undergoing, and the anesthetic registrar is asking you to help prepare epidural infusion. So epidural infusion is mainly for pain relief, analgesia. So which drug combinations would you prefer? Now all the A combinations here is with bupivacaine, which is your amide local anesthetic. Now you need to mix this local anesthetic with something else which will either prolong the effect of the local anesthetic itself, or it will add to your pain relief. So now depending on this concept, you have to choose an option. Now which one do you think here is best suited? Think about it and select one option. Alright, so let's have a look. Neostigmine is, as you know, a reversal agent, as anesthetists like to call it. It's a reversal agent. It reverses your muscle paralysis. And then look at epinephrine. Now epinephrine or adrenaline is a vasoconstrictor. So when bupivacaine and epinephrine are used together for nerve blocks or for subcutaneous infiltration, epinephrine will vasoconstrict that site and it will reduce the absorption of bupivacaine in the systemic circulation. So it helps to keep the bupivacaine at the site of injection for a much longer time. So it helps prolong bupivacaine duration. Ketamine is an IV induction agent. However, the preservative free type of ketamine or the S variant is usually used for intrathecal injection, not very much preferred for your epidural infusion. And then coming to fentanyl, we know fentanyl is an opioid. It is also a very strong painkiller or a pain analgesic agent. Therefore, bupivacaine and fentanyl would be the best choice to answer. Now let's look at it, why it is the best combination. So when you add fentanyl to bupivacaine, you are overall sort of diluting the bupivacaine concentration. So it comes in 0.25 or 0.5% concentration. So adding fentanyl and further diluting it, you can actually reduce the concentration to 0.125%. And fentanyl is usually added in 2 mics per mil. So if you have a 10 mil or 10 ml of your epidural infusion prepared, total concentration over there would be 20 micrograms of fentanyl. So what it does is it has an additive effect with bupivacaine. So when you use bupivacaine in such a low concentration, you are only blocking the sensory nerves, so with which you will achieve your analgesia. And motor system is not touched, it is kept intact. So actually the patients can mobilize, sit up, they can walk a little bit until the labor progresses, which will also help in progression of labor when they are mobilizing. So, and also bupivacaine causes hypotension when it is injected either in a subarachnoid space like in your spinal anesthesia or epidurally. So if you reduce the concentration, even hypotension is avoided. So better perfusion for the uterus and the baby as well. So the best option for labor analgesia is bupivacaine in a very lower concentration with your opioid like fentanyl. Alright, if you have any questions, queries, please feel free to send them in the chat box and I'll have a look at it and try and solve it for you. Okay, so coming to question number 5. Now, which of the following drug should be avoided in the patient with history of malignant hyperthermia? Your option A is etomidate, option B is propofol, option C is succinylcholine, and option D is thiopentone. Okay, so I'm getting some answers here and they have answered as C, which is Absolutely correct. So let's look at the question again. Which drugs should be avoided in history of malignant hyperthermia? You're absolutely right, and the correct answer is succinylcholine. Now, what is malignant hyperthermia? So it's a very rare autosomal dominant condition, and it is because of some abnormal ryanodine receptors. Now, where are these ryanodine receptors situated? They are situated on the sarcoplasmic reticulum or inside the muscle cell. So when they get activated, they cause massive, like a big release of calcium which is stored, and you know calcium helps in contractility. So when this massive calcium is sort of released in the body, that will cause muscle contraction, rigidity. Because the muscles are going into a sustained contraction, that's going to cause metabolic acidosis, hyperkalemia and hyperthermia. A lot of heat is generated in the body. So clinical features are muscle contraction, rigidity, hyperthermia, metabolic acidosis and hyperkalemia. Okay. And the triggering agents that we have are all the volatile agents. So the key to remember here is the triggering agents would be all volatile agents. So any inhalation anesthetic that would all be triggering and causing malignant hyperthermia. And one drug which is added to this list is your muscle relaxant, just one, which is a depolarizing muscle relaxant, not your other groups like atracurium, vecuronium, all of that. It's just succinylcholine. So just repeating again, for malignant hyperthermia, the group of drugs which cause problems would be all your inhalation anesthetics, even including ether, the oldest one, and depolarizing muscle relaxant, which is succinylcholine. I hope this was useful. So let's move on to our next question. Now, the question number 6 is most common cause of perioperative visual loss, or POVL, that is so commonly known now. It's a very upcoming topic, and we need to know a little bit about it because there is a chance it might be asked in your exam. Now, most common cause, option A, retinal embolism. So any embolism or thrombosis to central retinal artery or your vein. Then angle closure glaucoma, ischemic optic neuropathy like ischemia to the optic nerve, or option D is corneal abrasion. So which one do you think it is? Okay, so I have an option A here, which is partly correct, but our question is most common. So most common cause of POVL, perioperative visual loss, is ischemic optic neuropathy. Alright, so it's a very rare adverse effect, but quite a debilitating one. Imagine like losing one's vision, it's quite debilitating. So what are the risk factors for perioperative visual loss? So if patient is in prone position, when they lie prone, there is a risk of pressure on the eyes and the face as well. Then history of hypertension, if the patient already has history of hypertension or diabetes, so their blood vessels are also affected in these conditions. Then prolonged duration of surgery. Imagine patient is in prone position and going on in prone position for surgery going on for like 4 to 6 hours. That's quite a long duration with a lot of pressure on the eyes. Then if there is any intraoperative hypotension, if there is drop in blood pressure, or if there is hypovolemia. So both these things can lead to visual loss, and the most common pathophysiology would be ischemic optic neuropathy. Now this usually happens after spinal surgeries or if the patient has undergone a surgery on cardiopulmonary bypass. Alright. So most common cause, all of these can be causes of visual loss. But the most common cause you need to remember is your ischemic optic neuropathy, or there is like ischemia to the optic nerve. Alright, then let's look at question number 7. Alright, I hope this one is a little bit easier. So all of the following are colloids except option A is albumin, option B is gelatin, option C is plasmalite, and option D is hydroxyethyl starch. Please have a look at all the options properly. Albumin, gelatin, plasma-lite and hydroxyethyl starch. Can somebody answer please? Alright, so I have option B. So option B, gelatin. Unfortunately that is wrong because gelatin is also a colloid. But that's a good try. So let's have a look at our colloids. Now the correct answer here, which is not a colloid, is plasma-lite. Alright. Plasma-lite, also known as carboxylight in certain brand names, is a balanced salt solution. Now when I say balanced salt solution, is what it means is it has all the electrolytes in appropriate ranges that would be present in a patient's blood. And it is also isotonic. Isotonic as in it has the same salt concentration that is also present in the blood. Okay. So your osmolarity of plasma-lite is okay. So osmolarity is 294 milliosmoles per liter, which is quite close to your plasma, where it is 275 to 285 milliosmoles per liter. Sodium is 140 milliequivalents. Potassium is 5 milliequivalents per liter. It also has chloride at 98, magnesium 3, acetate 27 and gluconate 23. Alright. So if you look at your sodium and chloride, these are very different to your normal saline concentrations, where both are 154 each, which is quite high. So if you look at this, it is almost closer to your plasma levels. So normal plasma levels are 135 to 145. Normal chloride levels are up to 100 or 105. So these are very much similar to plasma, and therefore this is called a balanced salt solution. Okay, plasma-lite. Now what are colloids? So colloids are also known as plasma expanders, because when you give colloid to a patient, it can stay in the blood volume for almost 5 to 6 hours. So it's a very good plasma expander. Especially can be used in when there is a lot of blood loss happening and you do not have blood available immediately for use. So either you have blood derived colloids, which is albumin and other plasma protein fractions, and then you've got some semi-synthetic substances like dextrans, gelatin or hydroxyethyl starch. So just repeating again, the correct option here was plasma-lite, which is a crystalloid. Alright. Let's move on to question number 8. Alright. Now, which of the following anesthesia breathing circuit is best suited for children? Option A is Mapleson A. Option B is Mapleson F. Option C is Mapleson B. And option D is Mapleson D. So, which of the following circuits is best suited for use in children? Please have a look at the question again and please let me know which answer would it be. A, F, B or circuit D. Alright, so I'm getting some answers here which says D, Mapleson D. So let's have a look at the circuits first. So Mapleson classified these different circuits depending on where these components were situated. So let's look at them one by one. Mapleson A, you have your patient end, you have the APL valve, you've got a corrugated tubing, you've got a fresh gas flow and a bag, reservoir bag. So fresh gas flow is towards the machine end and towards your patient end you have your APL valve. Alright. Now compare this with Mapleson B. The fresh gas flow from the anesthesia machine end has jumped on to towards the patient end. So the B circuit is similar to A, except the fresh gas flow has jumped from this end to the patient end. Now in circuit C, it is exactly the same. However, the corrugated tube is missing here. So it's similar to your Mapleson B without the corrugated tubing. Look at D. So clear with A, B and C. Fresh gas flow jumped to the patient end. After that, Mapleson B and C are quite similar except corrugated tubing is absent. Then Mapleson D, if you look at between A and D, it is the other way around. Fresh gas flow is towards the patient end, but the APL valve has gone behind towards the machine end. So it's exactly the opposite of Mapleson A, which is your Mapleson D. Now if you look at Mapleson E, from here everything else has been cut off. So it is just the patient end fresh gas flow and a open tube, which is Mapleson E, also called as Ayer's TPs. TPs that we also nowadays use in a ICU. And then Mapleson F is a modification of Mapleson E, also called as Jackson-Rees modification or known as JR circuit. That's your Mapleson F, and this is the correct answer. This is useful in pediatric and in children up to 20 kgs of weight. That is because, look at it, fresh gas flow is close to the patient, so there is very less risk of hypoxia during anesthesia and during ventilation. Plus this bag is open-ended. So if any pressure develops in the system, that extra air can be let off. So low risk of barotrauma. Again I am repeating, fresh gas flow is close to the patient end, so less risk of hypoxia because you are continually giving oxygen and air mixture, and this bag is open-ended. So if there is extra pressure developed in the system, that extra pressure will be let off from the end of the bag, right? So Mapleson circuit F, which is Jackson-Rees modification of Ayer's TPs, would be a correct answer for use in children. Alright. So as I said, can be used in up to 20 kg or less weight, and it is the circuit of choice for spontaneous ventilation in pediatric patients. Now if you look at the efficiency of Mapleson systems, this is another MCQ that comes up quite often. So which is the best circuit for spontaneous ventilation? It's Mapleson A followed by D, F, E and then CB, right? So Mapleson A followed by D, F, E and CB for spontaneous ventilation. And if you look at controlled ventilation, DFE is much better preferred to BC and then last is A. Okay, so DFE is preferred for controlled ventilation, then BC and then A circuit. Alright, so I hope Mapleson systems was a little bit clear. Right, let's move on to our next question, question number 9. The following is true about pediatric airway except option A is large occiput, option B is macroglossia, option C is small epiglottis and option D is high larynx. I am repeating the options again. Option A is large occiput, option B is macroglossia or large tongue, option C is small epiglottis and option D is high larynx. Well done. So I have received some options, answers which says option C, and yes, that is absolutely correct. So let's have a look at the features of your pediatric airway. So children tend to have a very large occiput. So when you say that the position for intubation in adults is sniffing air, morning sniffing air position, here instead of putting a drape or a head ring under the head, you will try to put some support under the shoulders so that you achieve extension of the head because of the large occiput. Then they have a small mandible and contrastingly they have a large tongue. So that makes intubation difficult again in children. The epiglottis is very large or floppy, also called as omega shaped epiglottis. So as we see, rest of the features are present in the other options, but the answer will be large floppy epiglottis instead of a small epiglottis. Then the larynx in pediatrics is quite higher up, between C3 to C5. If you compare it with adults, it is between C4 to C6. So higher larynx, and this is also an important point to remember. The narrowest part of the larynx is your subglottis, that is below the vocal cords, compared to adults where where the narrowest portion, where the narrowest part of your larynx is your glottis. So in the pediatrics, if you're trying to put a size 4 endotracheal tube, it will go through your vocal cords. But if the size is quite narrow beyond the vocal cords, then you will face an obstruction while putting in the tube. So always remember, narrowest part of larynx is your subglottis, below the vocal cords. Alright. So small epiglottis was the correct answer, as in this is not a feature of the pediatric airway. Alright, I hope this is useful to you, and you all are taking down notes as well. Okay, let's look at our question 10. Now the volatile anesthetic agent which undergoes highest metabolism in the body is, option A is halothane, option B is isoflurane, option C is sevoflurane, and option D is desflurane. So volatile anesthetic agent with highest metabolism: A halothane, B isoflurane, C sevoflurane, and D desflurane. So any volunteers for the answer here? Alright, no worries. So let's have a look at the different metabolism rates for these volatile anesthetics. So this table reference is from Miller's textbook, and nitrous oxide almost undergoes zero metabolism in the body, like no metabolism at all, goes in and comes out of the body entirely. Then desflurane undergoes very minimal, 0.02, so quite minimal, followed by isoflurane, which is 0.2%. Enflurane is 2%, sevo is 2 to 4%, a little bit higher than enflurane, and halothane undergoes the highest metabolism rate, which is 25%, quite a large proportion of halothane that undergoes metabolism. Now this gets metabolized in your liver, and you know these are like polyfluorinated chlorinated agents. So in the olden days, when halothane was one of the best volatile anesthetics available, and if the patient had multiple exposures to anesthetics, this used to cause something called as halothane hepatitis. It used to actually affect the liver, and in certain rare conditions it used to cause hepatocellular necrosis as well. And the reason is because this undergoes the most amount of the most proportion of metabolism. All right. Okay. So let's have a look at our question number 11. All right. This is a little bit more clinical. So in a patient with history of temporal lobe epilepsy, which of the following drugs should be avoided? Option A is propofol, option B is thiopentone, option C is etomidate, and option D is ketamine. Now let's look at the question again very carefully. So in a patient with history of temporal lobe epilepsy, here the key word is just epilepsy, because epilepsy in general begins from temporal lobe. So just to confuse you, they might have put up like a bigger word, but look at the clue. It's epilepsy, history of epilepsy. So which drugs can cause, can sort of worsen this epilepsy? So either it's propofol, thiopentone, etomidate, or ketamine. Can somebody volunteer? Any volunteers for the answer here? All right. So let's have a look at our answers here. So propofol, it's an induction agent or an IV anesthetic agent, and this actually reduces your cerebral blood flow, reduces your cerebral metabolic rate as well, and it's actually an anticonvulsant. So if you remember your status epilepticus pathway, that the way to treat status epilepticus, propofol comes at stage 4. When everything else has failed, you actually anesthetize the patient, put them on propofol infusion and put them off to sleep. So, and this is also used for burst suppression of EEG. Burst suppression as in suppressing those spikes. So if a patient has refractory seizures, refractory as in even after 2 to 3 different types of anti-epileptic medicines that you have given them, they are still continuing to have seizures, you can actually give them propofol infusion and just completely sedate them. So propofol is actually very good for as an anticonvulsant in epileptics. The thiopenton, if you remember, thiopenton traditionally used for barbiturate coma. So it is also an anticonvulsant. It decreases the cerebral metabolic rate, and if the patient has again refractory seizures or raised ICP which is not being controlled by any other medications, then thiopenton was used as in a continuous infusion format, and this was called barbiturate coma. Alright, the third option, etomidate. Now this is your correct option. Now etomidate is a imidazole which is also used as a IV induction agent, and especially in patients who have low ejection fraction, like ejection fraction of 25 or 30, where if you give any other induction agent, your cardiac output and so your blood pressure will drop. So etomidate has the quality where it maintains your blood pressure, does not decrease it at all. So this is actually like used by cardiac anesthetists when they have to anesthetize a patient with very low EF. However, it has the potential to produce epileptogenic spikes. So it has been associated with generalized seizures in rare cases, and therefore you won't be using etomidate in any patients with a history of epilepsy. So actually when we do neuroanesthesia and where we are doing surgery for epilepsy, like we want to take off the part of brain which generates those epileptic spikes, if the surgeon cannot see on the intraoperative EEG, then we actually give a small dose of etomidate to generate those spikes just to identify these epilepsy areas in the brain. So here the correct option is etomidate. Now ketamine is like a double-edged sword. By that what I mean is, when you give it in sub-anesthetic doses, less dose compared to what you would give to put the patient off to sleep, then it is used as an analgesic agent. And here also they have seen spike patterns on EEG, but when you give it in a very high dose, like your anesthetic doses, 2 milligrams per kg, it is nowadays soon becoming one of the very important drugs in management of refractory seizures. So here when everything else fails, ketamine as an infusion is being used to control seizures. So the question was, what would you avoid in a patient with epilepsy? And here out of all these 4 options, the correct option will be etomidate. Alright. Then moving on to our 12th question. Okay. So a 45-year-old patient with history of hypertension is posted for laparoscopic cholecystectomy. Which of the following antihypertensives should be omitted on the day of surgery? Option A is amlodipine, option B is bisoprolol, option C is ramipril, and option D is furosemide. Again, there is a patient who is due to undergo surgery, laparoscopic cholecystectomy, and he has history of hypertension, for which he is on all these probably medications. So out of this, which one will you stop on the day of surgery? So one is a calcium channel blocker, beta blocker versus a ACE inhibitor versus a diuretic agent. So can you please look at this, and what do you think is the correct answer here? Alright. So the correct answer here would be your ACE inhibitors. Okay. So as per the preoperative evaluation that is given in Miller's textbook of anesthesia, if your patient has systolic blood pressure more than 200 and diastolic blood pressure more than 115 millimeters mercury on the day of surgery, then you would not go ahead with this procedure. You would postpone the procedure. So antihypertensive drugs are usually continued on the day of surgery because you want to avoid massive swings in your blood pressure. So if you avoid all the drugs, what will happen is patient will have perioperative hypertension. So this can actually interfere with wound healing, will cause a lot of complications. So the guideline says that apart from ACE inhibitors and ARB, angiotensin receptor blockers, you can continue all the medications on the day of surgery. But ACE inhibitors and ARB blockers, they are associated with severe hypotension if continued on the day of surgery. Okay, I am repeating again. ACE inhibitors and ARB blockers are to be omitted on the day of surgery as they can lead to refractory hypotension. And why this happens is because your renin angiotensin aldosterone pathway is blocked. Now RAS pathway or the renin angiotensin aldosterone pathway is very important for maintaining the blood pressure, right? So if all the pathways are blocked in the body, then the patient will have hypotension and it will be very difficult to manage it with fluids or with inotropes or vasopressor support. So all these drugs are usually continued on the day of surgery, even your beta blockers, calcium channel blockers and your furosemide diuretics as well. You can check electrolytes before the surgery and make sure it is in normal range. But the drug that you would avoid is ramipril, which is a ACE inhibitor. If any doubts or questions, please do ask me in the chat box. I am continually having a look at that as well. Alright, so let's come to the final question today. Okay, now this is a history of anesthesia question. So first successful demonstration of ether anesthesia was conducted on which day? 8th November, option B 15th May, option C 16th October or option D 25th July. So the first successful demonstration of ether anesthesia was on which of these days? Can someone please volunteer and let me know which option do you think is correct? Alright, so the correct option here is 16th October. So 16th October is also known as the World Anesthesia Day or Ether Day. So on 16th October in 1846, the first successful public demonstration of ether anesthesia was performed by William Thomas Green Morton or WTG Morton. So this was done in a patient undergoing jaw tumor surgery where ether was given and the patient had a successful completion of surgery and no pain at all, right? And this historical event took place in the amphitheater of the Massachusetts General Hospital. So they still have this amphitheater and they call this place as the Ether Dome. So this was successfully done on 16th October 1846, and after this anesthesia as a field was revolutionized and many surgeries were possible, and therefore this is a very historical day for us, also called as the World Anesthesia Day or Ether Day. Alright, I hope that all of you found this session very useful, and so remember, we will be doing our next live session on 23rd February, which is day after tomorrow at 8:45 p.m. where I will be completing the rest of the questions 14 to 25. If you have any questions right now, please feel free to send me on the chat box. Okay, so the next session, as I said, is on 23rd February, 8:45 p.m. on Medicoz Community YouTube channel. Alright everyone, thank you very much for joining us, and I hope that this session was useful to you for your exams, and I really hope to see you all back again day after tomorrow, which is the 23rd at the same time, 8:45 p.m. Okay guys, thank you very much.